We now have our second presenter, Dr. Chafic Karam from OHSU, soon to be UPenn. So take it away, Dr. Karam.
And thank you for inviting me. Yeah, we're very sad for Dr. Janice Wiseman. I met her last fall also during the meeting. It's very sad. She's such a nice person, but it's really a tragedy. That being said, we'll talk a little bit about neurological complication of ATTR amyloidosis. This is the outline. We're gonna first do an introduction of the neurological systems. Then we'll discuss how amyloid damages the nerve. What are the neurological signs of hATTR amyloidosis? How do we detect amyloid challenges in hATTR from a neurological perspective? And then treatment strategy for hATTR amyloidosis. So, as you know, the human nervous system consists of the brain, spinal cord, and the nerves that exit the spinal cord. The nerve that exit the spinal cord have motor function, sensory function, and autonomic function. The motor function is usually voluntary, so the brain sends a signal, for example, down the corticospinal tract that travels down the nerves, and if you want to, for example, make a fist, it will activate the forearm muscles to make the fist. The sensation, if you're, for example, touching water and the water is warm, it will carry the sensation down up the nerves to your spinal cord and then to the brain and tell your brain that the water is warm. Whereas the autonomic nervous system is more automatic, if you want. It does things without you thinking about it. So for example, think about eating some food. You first start by initiating the swallowing mechanism that is conscious initiated. And then once you start swallowing, then you don't think about it. The food would just travel through your esophagus, then to your stomach, then to your intestine, and eventually it will go through number 2. So this is how you don't think about it. And these are systems that are affected in amyloidosis, especially hATTR. We are talking today about ATTR in general, but from a neurological perspective, we're more interested in hATTR just because it causes more neurological symptoms and involvement than wild-type TTR. And we will get back to this in a little bit. This is a picture of the nerve, and the nerves, you know, they communicate between each other. There's the cell body, there's the axon, and around the axon there is myelin. The issue with amyloid is that it causes axon damage. And when you have axon damage, it's hard to rebuild the nerve. If you just have myelin damage and you control the disease, you may actually be able to remyelinate, and that's not a big deal. But when you have axonal damage, which is what happened in amyloidosis, the nerve sprouting take a long time to grow back. And sometimes it may never grow back. And if it does, it can grow back imperfectly, if you will, given that you stop whatever is causing the axonal damage. So you've seen this picture before many times. The liver is the main organ that makes the TTR protein, which is responsible for the ATTR. There are other organs in the body that makes it. There's the brain can make it, the eye can make it, the pancreas, the nerves, etc. But the majority of the TTR comes from the liver. And that is why the treatments target mainly the liver. You know, initially the first treatment for ATTR amyloidosis or hATTR was liver transplantation. You put a healthy liver without a gene mutation in a patient with hereditary ATTR, and that worked really well, especially in certain mutation and if done very early in the disease. And now with the new medication that we have, the gene silencer or the knockdown therapy, they target directly the liver to suppress the production of the TTR protein. So this TTR tetramer that has a function in the human body. It transports vitamin A, it transports the thyroxine or thyroid hormone. And it also probably has other function that we don't quite know very well at this point. In disease state, whether it's wild type or hATTR, the inherited or mutated state, you have dissociation of this tetramer, misfolding of the monomer, and then it accumulates and causes the amyloid, causing either heart problem, nerve problem, both, GI issues, and so on. This picture showed you a biopsy of a nerve. So as you see the pinkish material here and the reddish material, these are the amyloid. There's many different ways we think the amyloid can cause nerve problem or nerve interfering with the nerve signal or nerve damage. One of them is direct toxicity to the nerves. A second one is disruption of the normal architecture of the nerve. And the third is by interrupting blood flow. And one question somebody asked about is why is the neuropathy usually starts pretty early, whether the heart, once you diagnose it, it's usually pretty advanced. And we don't really have a great idea about why this, but I think that what happens is that in the heart, the amyloids start accumulating and the heart can compensate nicely for a certain time until you reach a certain threshold. And once you reach a certain threshold, you start having the symptoms. Whereas in the nerve, you start having the pain very early on in the disease, even before there's a lot of accumulation of amyloidosis. So that's just my kind of simple explanation, but I don't really know if there's any proof about that. This is another picture of a nerve, and you can see here the amyloid is in the blood vessel. So when that happens, it can interrupt blood flow and cause ischemia and nerve damage via ischemia, in addition to the toxicity that I mentioned before. So you all know ATTR comes in two flavors. There's the hereditary or mutated ATTR, which runs in the family. It's autosomal dominant, meaning 50% of the offspring may be carrying the gene. But it doesn't mean that, you may have sometimes the whole family carrying the gene. It just, everybody has 50% chance of getting the gene. And unfortunately, in a certain situation, we have everybody get it. And so other ones, we don't have anybody inheriting the gene, so which is good. And depending on the mutation, there's over 120 mutation with this gene. In the US, the most common is the V122I, mainly present with heart disease. In the rest of the world is the V30M, which is also called the V50M now, and it mainly presents with neuropathy. But a lot of patients have both, when we say present with neuropathy or present with cardiomyopathy, we're meaning this is the kind of predominant symptom. But a lot of patients with V122I may also have neuropathy. Wild type ATTR happens mainly in older wild male, mainly have heart disease. A lot of them may have carpal tunnel syndrome, spinal stenosis, biceps tendon rupture, and trigger fingers. With this type of amyloidosis, it is unclear if neuropathy is part of the disease. There are many reports that there's a lot of these patients who have neuropathy. The issue is that this wild type ATTR affect also older people, and older people tend to also have neuropathy and spinal stenosis. So it's unclear if this is the cause of their neuropathy, but this is still to explore. Now, what are the signs? The neuropathy in hATTR, most of the time, the neuropathy is length dependent. When we say length dependent, we mean the distal limbs are affected the most first. So meaning the toes start getting numb or start burning or start tingling. And as the disease progresses, it can go up to the ankle, the symptoms, and then up to the mid-shin or even knee when it's very severe. And at that time, you start having symptoms in the hands. The symptoms that people experience are numbness, burning sensation, prickling sensation, pain to light touch sometimes, balance difficulty. These are from the sensory aspect of the neuropathy. From the motor aspect, you start having weakness. You start having dropping in your toes or your foot, which will cause tripping. It can have difficulty standing on your tiptoes, difficulty opening a jar or holding a pen, opening a door with a key, and so forth. And some patients with neuropathy also have autonomic nervous system involvement, which we talked a little bit about earlier, and I will discuss more in details the science of dysautonomia. So how do we diagnose neuropathy? Neuropathy is pretty common actually in the general population. It is one of the most common neurological problems. There are hundreds of causes of why people can get neuropathy, which makes it challenging why people with hATTR may be misdiagnosed or have a delay in diagnosis. To make the diagnosis of neuropathy, most of the time you have to have the patient tell you about their symptoms. If they don't, when you examine them, you find some sensory loss. And then when you do your nerve conduction study, you may find these abnormalities as well. Other ways to prove that the patient has neuropathy is by doing skin and nerve biopsy, which also can show you the amyloid. So it can serve two purposes, and quantitative sensory testing. The autonomic dysfunction and hATTR amyloidosis are common. A lot of time, actually, this is the first symptom, but because they're not specific, the patient may suffer from these symptoms for a while before they get to the diagnosis of amyloidosis. So in men, we found that one of the most common problems is erectile dysfunction. Constipation and diarrhea can be very problematic, and it can actually prevent people from visiting the doctors. I have many patients who cannot come and see us just because they have to be very close to a bathroom, for example. Early satiety, meaning when you eat just a few bites, you feel full. And if you keep eating, the food may regurgitate and you get nauseous. And the reason is because the stomach is not functioning well. The nerves going to the stomach are not telling the stomach to contract and push the food down the intestine. OH, or orthostatic hypotension, is a major problem as well. When people stand up, they may feel lightheaded and they may faint and injure themselves when they have this problem. It is caused by a drop in blood pressure, and it's caused because the nerve going to the blood vessel are not constricting well when the patients go from a laying down position or sitting to a standing up. And then because the nerve going to the sweat gland may also be affected, the patient may have lack of sweating and they could not tolerate heat very well because their body get hot very quickly and they cannot they cannot regulate the temperature. Orthostatic hypotension, the symptoms most of the time people have lightheadedness and we can make the diagnosis quickly, but sometimes it can be as simple as confusion. And when you see people standing up and getting confused, you have to think about a drop in the blood pressure. Sometimes there is neck and shoulder pain, which we call coat hanger headache, chest pain, and shortness of breath when you stand up. How do we diagnose dysautonomia? Of course, the symptoms that we discussed, constipation, diarrhea, early satiety, which may lead to weight loss, lightheadedness when people stand up, heat intolerance. All of these symptoms are not really very specific for amyloidosis. They can be side effect of medication. Somebody can have IBS or irritable bowel syndrome, and the symptoms can be the same. So really, you have to be careful with interpretation of any symptom. We like to do autonomic reflex screen, where we check how the patient is sweating. We put them on a tilt table to check how the blood pressure and heart rate are changing when we tilt them up and so forth. And these can also be done at the clinic or at home. You can be sitting for a few minutes, laying down for a few minutes, and then stand up and take your blood pressure after 1 minute of standing up, 3 minutes and 5 minutes, and see how the blood pressure is changing. Carpal tunnel syndrome has received a lot of publicity because And many times, people with carpal tunnel syndrome uh, or people with amyloidosis have a history of carpal tunnel syndrome, which happened, months or even years before the diagnosis of systemic amyloidosis. And what is carpal tunnel syndrome? It's a very common disorder. There's the nerve that goes to your thumb, your index, and your middle finger, and a little bit your fourth finger, and that goes through a narrow canal. And with repeated activity, for example, any manual labor, cook, for example, if you're a cook, or if you use your hands a lot during your work, typing, and so forth. And of course, if you have amyloidosis that deposits in this canal, in this ligament, and causes compression of the nerve, you can have symptoms of carpal tunnel syndrome. Usually people start having numbness and tingling in their hand. It may wake them up from sleep, and they have to shake their hands for the symptoms to go away. And as the disease progresses, they may be holding a phone or a book, and then their hands go numb, and they become permanent. And this is, important to know that it could precede amyloidosis. The issue is that it's common in the general population. So as you can see here, 5 to 10% of the general population don't have amyloidosis, yet have this condition. It's very common among diabetic patients, those with inherited neuropathy, and so forth. So although it could be a sign of early amyloidosis, keep in mind that many patients still get it without really a good reason. We did a small study in our center to see how do people first present with hATTR. And as you can see, carpal tunnel syndrome happened in about 50%. That is really the first manifestation. Dysautonomia in about 25%, cardiac manifestation and neuropathy each in about 15%. hATTR amyloidosis is a systemic disorder, meaning it affects multiple organs. And careful investigation, careful question can help us determine which organs are involved. This is different from wild-type TTR. Wild-type TTR mainly affect the heart and the tendons, as we mentioned before. However, hATTR causes neuropathy, cardiomyopathy, GI issues. Sometimes it can affect the kidney. Sometimes it can affect the eyes, the brain. And a lot of the treatment that we currently have target, as I said, the liver or the bloodstream with the stabilizers. But as these treatments are increasing survival, we may have more issues with the eyes and the brain because they don't penetrate or they don't affect the amyloid production on the brain and in the eye. So that may be something that we may see more in the future. There are currently trials to look at how we tackle this issue. Now, to the detection of amyloidosis, you saw before with the imaging, with the echo, PYP scan, MRI for the heart. Unfortunately, for the nerve, we don't really have anything commercially available. There are some studies going to look on what is called MR neurography and looking at the sciatic nerve, for example, and seeing if there's amyloid deposition there. These are still kind of investigational. There are other studies looking at kind of tracers that can stick to the nerve, to the amyloid in the nerve, and you can see it as well. But really at this stage in the clinic with your doctor, there's not much imaging you can do to find amyloid in the nerve. So if the imaging of the heart is negative and you want to look for amyloidosis, you're going to end up having to do biopsies. You can, in theory, biopsy any organs in the body. The least invasive are going to be the fat aspirate and the skin biopsy, but the yield in those conditions is low, meaning because we're taking tiny pieces and the amyloid is being deposited in a heterogeneous pattern, you may biopsy an area that doesn't have the amyloid. So the doctor may do multiple biopsies, unfortunately, or repeat the biopsies over time. You can do a GI biopsy, you can do a lip biopsy, salivary gland, and of course a cardiac biopsy and a nerve biopsy as well. But again, having a negative biopsy and negative imaging does not necessarily say that you do not have the amyloid. You can still have it, but we're just biopsying places where we're not getting the amyloid. So what are the challenges in hATTR? This is a rare disease. There's increased awareness right now with this disorder. With the advance of the PYP scan, there's, I think, also more of the cardiac diagnosis. Unfortunately, people may go years with an incorrect diagnosis until they reach the correct diagnosis. The genetic testing that we have for hATTR now, and the fact that it's free in the US through two of the pharmaceutical company that are developing drugs for this disease is really helping us a lot. But we've seen patients diagnosed with CIDP, ALS, fibromyalgia, irritable bowel disease, and peripheral neuropathy from other causes. If you have a patient who has neuropathy and they found that their sugar is a little bit high, it may be blamed on diabetes, or if they drink a little bit of alcohol, maybe drink on alcohol. So it's always important to make sure we're not over-interpreting or attributing the disease to certain other more common condition, and to really investigate these disorders carefully. Some clues that can tell us that this neuropathy is caused by amyloidosis. The autonomic dysfunction that I spoke about today is very important. Most neuropathies don't give you severe autonomic neuropathy, but amyloidosis does. Any rapid progression of the neuropathy, it's unusual in other type of neuropathy, but it's very frequent in amyloidosis. And of course, having neuropathy plus cardiac disease should point or should prompt the doctor to look for potential amyloid in the heart and the nerve. Finally, if patients have carpal tunnel syndrome, they have surgery, they don't get better, it may be something to think about, that this could be amyloidosis as well. This picture just shows you how the neuropathy progresses with different type. We looked at Charcot-Marie-Tooth, which is an inherited neuropathy. We looked at idiopathic neuropathy. We looked at diabetic neuropathy, and we looked at hATTR. And as you can see, the only neuropathy that really progressed very quickly, everything that goes up, meaning it's progressing quickly, it's the hATTR neuropathy. So that could be a clue that there's something, for example, if you have diabetes and your neuropathy is progressing very quickly, then it would be a good idea to look for amyloidosis in those situations. Other challenges are, I think one of the major challenges really is the people who are screened because they have family members who have amyloidosis, they undergo genetic testing, and they are found to have a mutation in the gene. And the question is, when do you start treatment in those patients if they don't have symptoms? Or if they have symptoms, are these symptoms related to amyloidosis, or is there something else? So for example, we've had a patient who had the genetic mutation, but they were also having regurgitation of food and early satiety, which we said it was one of the signs of dysautonomia. But upon additional investigation, this patient was found out to have esophageal cancer. So we cannot just blame and say, this is, oh, you have the mutation, and blame everything on amyloidosis. I still think you need to do a careful examination and kind of do the adequate investigation to make sure there's nothing else going on. We've also had patients with the mutation and they had neuropathy, but their neuropathy was actually related to uncontrolled diabetes. So the misdiagnosis or the overdiagnosis go both ways. And of course, when do you start treatment? Somebody asked before about diflunisal. If you just have the mutation and we don't have symptoms, do we take diflunisal? Do we take one of the gene silencer, or we wait tafamidis? And the answer is just, we don't really know. Some people in the same family, you can have one brother with severe disease and the other sibling with no symptoms at all, and the other siblings may be much older. So there are certain reasons we don't fully understand why within the same family some people go on to develop disease and some other don't. So taking medication for 10 or 15 or 20 years and you never develop the disease, or you develop it when you're 80 or 90, doesn't make a lot of sense, because any medication will have side effects and so forth. So what are the treatment strategy for hATTR amyloidosis? From a neurological perspective, we focus on two major aspects of treatment. We can try to control the symptoms. People with neuropathy have pain, and pain can affect dramatically quality of life. So we have to try to control the pain. They may have severe diarrhea or constipation and so forth. So this is what we mean by symptomatic treatment. The purpose of treating these symptoms is to help, make life a little bit more tolerable for our patient, have them enjoy some stuff, whereas specific TTR treatment alter the course of the disease. They may not necessarily help with the symptoms, but we know from the trials that over time, they may slow down the progression of the disease and maybe even improve lifespan, increase their lifespan and survival. So going back to the picture of what is the major cause of this production of the TTR and cause of the disease. As you recall, the liver is the organ that makes most of the TTR protein. And for a long time, liver transplant was one of the main treatment for this condition. Now that we have gene silencer, we're using those more. We have currently 2 on the market in the US, inotersen or Tegsedi, and patisiran or Onpattro. One is an infusion every 3 weeks. You need to be pre-medicated with that, with steroids, anti-acids, and anti-allergic medication. But there's no monitoring with that medication. That's Onpattro I'm talking about. And Tegsedi, it's an injection. You do it yourself at home once a week, but you do have to monitor your platelet, your kidney function, and your liver function every now and then. The platelet every week, the kidney function every 2 weeks, and the liver function every 3 months. And they are currently under investigation, kind of enhanced treatment or enhanced formulation of these drugs. With the new version of patisiran, it's going to be a subcutaneous injection every 3 months. And with the new injection of inotersen, it's going to be 1 injection every month without apparently the need to monitor the platelet and the liver function and the kidney function. And they designed these drugs to suppress even further the TTR production. The patisiran and inotersen suppress the production of the TTR by about 80%. The newer formulation, from what I've heard, go up to 90% plus. Then once the TTR leaves the liver and goes in the blood, then you have method to stabilize it in the blood. We've heard about diflunisal, we've heard about tafamidis. There's tolcapone, which is interesting because this is a drug that can penetrate very well the central nervous system and act on the brain. So this may be useful for people who develop central nervous system or even ocular complication. And then once the protein dissociate and cause the amyloid, then there are different strategies. You heard about doxycycline, TUDCA, and the PRX004. There's no good proof for these drugs yet. The PRX004 was in phase 1 and they finished the phase 1. We're awaiting to see what the results are and if they're gonna go to the phase 2. It's an antibody that attaches to the amyloid. A lot of question I get about using a combination therapy, meaning that if you're using a gene silencer, such as inotersen or patisiran, can you add a TTR stabilization, such as tafamidis or diflunisal, And eventually, can you add even a third one like PRX004? And these are very interesting questions. And we have some studies that are actually looking at, doing a combination therapy. So, for example, from what I know, the new version of the Tersin or Leica compound, in their trial, they're allowing some patient to be on tafamidis. So we'll see how, if they can get any statistical analysis and see if this will be useful or not. Going to the symptomatic treatment of hATTR amyloidosis, I'm not going to go into the cardiac medication. They were mentioned before with the diuretic, etc. But for the neuropathy pain, there are many different medications. Some of them belong to the category of antidepressant, and some other belong to the category of anti-epileptic. So you probably all heard of gabapentin, Neurontin, Lyrica, Cymbalta, amitriptyline, and so forth. So there's no really magic bullet, and each of these medications have their own side effects. And unfortunately, a lot of time it's trial and error. So we ask the patient to try certain medications, see if they help. If they don't, we'll stop them and try something else. Of course, getting to the appropriate dose is also important. For the diarrhea, antidiuretic are usually helpful. For the nausea and vomiting, we also have different options. For orthostatic hypotension, we can use midodrine and other medication as well. And for constipation, fibers, Miralax, Senancolase. So always tell your doctor, even if you're just already on Patisiran or on Tersin, but you're still suffering, we have a lot of medication that can help with your symptoms of diarrhea, neuropathy, pain, and so forth. So I think it's worth trying them. And thank you very much. I will stop here, and I think we will do the question. I don't know if you want to do the question now or in the Q&A session.
Well, thank you so much, Dr. Karam. That was really wonderful. And we have Q&As going on in the bottom of the screen, and we ask all of our panelists to take part in it. Some of them are specific to neurology, some to cardiology. Some of them are not specific, but if you think it falls into your area of expertise, panelists, we ask that you answer them. But Dr. Karam, I have one question that I want to ask you right now, because it touches on something that we had asked Dr. Grogan, and that was for the hereditary patient that is asymptomatic, but everyone else in their family is, symptomatic and on treatment. And the question was, that patient's doctor recommended diflunisal, and the patient was concerned about that. And you brought that up again from a neurological point of view. And you said that there's no point in giving someone 15 years of medication if they don't need it. But my thought is, how do you know that if you're putting that patient on diflunisal and for 15 years they've never needed it, how do you know that it wasn't the diflunisal that kept them from having amyloid fibrils deposit, from the TTR? And how would you not know whether it was the diflunisal that was keeping them from becoming symptomatic rather than the disease?
Yeah, you're totally right. I don't tell patients don't take diflunisal, actually. I do explain things to the patient. I really like, to have the patient involved in their care. At the end of the day, who's better kind of an advocate for the patient than yourself? I mean, it's your life at the end of the day, it's your health. You're going to be more kind of involved in it than any other person. So I like for people to make their own decision, but I like to tell them, all the different pros and cons of things. So, and people have different opinions. Sometimes people tell me, what do you think? So if I was in their position, I sometimes even, I don't know, I'll have to think a lot about it. Do I take diflunisal or just wait? If my, wife or my father or my mother or my kids have something like that, what do I tell them? And it's a very difficult question. We know from looking at different families, you have young people develop the disease early on, in their 30s and 40s. and their siblings in their 60s and 70s or even 80s never developed the disease. So it's at this time we don't know. I think in the future we will know. And we're looking at very interesting, biomarkers, and the different companies are looking at those biomarkers. I don't know if you heard about the neurofilament, serum neurofilament light chain. So neurofilament is an indicator of nerve damage. And there've been a few recent publications looking at those very early in the disease. You can measure them in the blood. So maybe this is what we'll do in the future. We'll just keep measuring that. And once we see that they're trending up, we tell the patient, okay, it's time to start treatment. But at this time, really, it's, your guess is as good as mine. You go on diflunisal and maybe it will help you, and maybe you don't need it. The only issue you have to be careful with diflunisal, it's an anti-inflammatory drug. We know with all the anti-inflammatory drug, there's an increase of risk of GI irritation, even ulcers and bleeding from the ulcers, which can be very serious. It can cause kidney problems in certain condition, and it can also increase the risk of heart disease. So this is the reason why you have to be careful telling people, if the patient is very anxious and if they want to try it, I'm happy to prescribe it. Diflunisal is not an expensive drug. You can go pick it up from most pharmacies in the US. I guess not in Canada anymore, but in the US you can still pick it up. But yeah, it's a great question, and I don't really have a very good answer at this point. So I let the people decide if they want to take it. I'm happy to prescribe it. If they say I'd rather not deal, especially if they have a sensitive stomach to begin with, then I would tell them maybe avoid.
Thank you so much. It looks like it might be expensive in the future if Dr. Grogan's right and they decide to, tell people what, I guess relabel it or whatever. Okay, thank you so much for that presentation. It was great. And again, all of the presentations will be put on our website as soon as they can. And remember, Dr. Karam will be back with us for our Q&A, and he's going to be answering questions on the board on the Q&A, because I think there's some just for you, Dr. Karam, and all of our doctors have been taking part, and pharma and everyone. So it's been really great.